Hi, I'm Dave Myers. I'm the Senior Fellow here at the Berks County Community Foundation, and I will welcome you to our community forums. We do these periodically on issues of importance and topics that are significant to the community and have an impact on the community. I need to do a quick reminder here. The opinions expressed by the program participants do not reflect the views or position of the Berks County Community Foundation, but are their own. What we do is we ask you to keep your camera on if you can, so we know we're seeing real people, but to mute your microphone so that we don't get a lot of background noise. We ask you to use the chat function at the bottom of the screen. You'll find it at the bottom of the screen there to submit questions and comments. Once we get through the formal presentation, we will go to the questions and comments. If we don't get them all answered, we will share them with our presenters and have them give us responses. We will share the recording with everybody who registered. We often get people who register but are unable to make it for some reason during that day. So we share the video, give them a copy of the video. We also post the video on the YouTube website for the Community Foundation and share it with BCTV. So we will get some play beyond what we're going to hear and see today. We will also share a report that was done relative to this topic with everybody who registered for the event as well. So with that, thank you all for joining us. On behalf of the Community Foundation, we're glad you're here. And I'm going to turn this over to Paul Jansen, who is the head of the Centers for Excellence in Local Government here in Berks County. Paul, to you.
Thank you, Dave. So the process that has evolved at this point is as a result of a number of failures in Berks County among our ambulance providers. Since 2015, there have been 8 different agencies that have ceased to operate. And obviously, if we have an ambulance operation that ceases to operate, we have to go to mutual aid and pick up the pieces and make sure that ambulances get to locations. But it has accelerated over the last couple of years and created a real concern that maybe we're not going to have an ambulance that can respond if a call comes out. So with that, we talked about it at the Center for Excellence in Local Government and with the Community Advisory Board. And with us today is Chip Bilger, who is the director for Western Berks Water Authority, but also president or chairman of the Board of Supervisors for Lower Heidelberg Township and chairman of the Community Advisory Board. And he has spent a lifetime in emergency services as well as all those other topics or all those other jobs that we have done. And so we were talking through that, Chip and I were talking through that with the board and recognized that it was really important for us to get somebody who had the perspective of the entire county involved. And that happened to be Brian Gottschall, who is the director for the Department of Emergency Services for Berks County. What we didn't know at the time was that Brian has always been a functioning ambulance provider with the Lower Alsace ambulance crew. And so while he worked for the county full time as the director for the Department of Emergency Services, he has always run ambulance with them for the last, I guess, Ryan, you can correct me, about 25, 30 years. So he has really good insight into the issues that are there. And one of the first things that we ran into is that this is not a county issue. It's the same with police, and it's the same with fire. In Pennsylvania, the county does not have any ability to actually provide those services. They provide the 911 center, they provide the communications between the providers, but the county is not legislatively allowed to actually operate the system. So Chip, myself, and Brian started to figure out how we needed to get through this process. And Chip, why don't you describe the process we went through?
We're going to talk about that in depth once we start the PowerPoint. But I think what I want to do, Paul, is talk about the PowerPoint itself. The PowerPoint was really put together to inform the elected officials of the county of this issue and this problem. That was our first goal, was to make sure that the people that are responsible for funding ambulance services are aware of the issue. Dave has chosen to allow us to speak to you. This is really the beginning, the first time we're talking to the public about this issue and frankly, the crisis that really is amongst us regarding providing emergency medical services. So when you look at the PowerPoint presentation, just remember that it was geared towards the elected officials. Some of the stuff there is really talking about the importance of funding and things like that. So as we talk to you guys today, as the first outreach to the public, just be aware of the PowerPoint presentation was really developed for the elected officials. Now, that being said, once again, the importance of getting the word out to the community about this is really, really important to us. Mayor Dean asked the question in the start, what about Washington, D.C.? Harrisburg's on that same list. We're going to talk about all those issues from a state and federal funding level as we go through the PowerPoint presentation. So I think at this point, we'll turn it back to Brian and we can start the PowerPoint. And a lot of these questions hopefully are going to be very clear for you on where we're going to go with this topic today.
Brian, why don't you focus your opening comment on what is your background as a emergency medical provider?
Sure. Thanks, Paul. Yeah, as you mentioned, I do work for the county in the Department of Emergency Services as my full-time job, but I've been a fire and EMS provider in the county, and in surrounding counties as I moved around for school and things like that since 1989. You mentioned I currently am active with Lower Alsace Ambulance. That is true. However, that has not been for that full 30-some years. I've worked for other EMS squads prior to that. I'd be very cautious about using some of the terminology that Paul used about expertise, but I will say that I've been around a little while and I've seen some stuff and I know some people. So I appreciate Paul's observation that I was able to bring some of that perspective to the effort. That was really the objective, to make sure that CELG had someone available to them that had some technical expertise, and where that expertise wasn't readily available, knew who we could tap on or talk to get the information that was necessary. So Paul and Chip, we prepared to begin going through the slides?
Let's go.
Very good. So I think, again, for the audience, we appreciate your consideration as we present this the first time to members of the general public versus just elected officials. We're going to try to make this pertinent and germane to the viewpoint of members of the general public while still following the same format. Some of the things that we want to emphasize about this presentation as we delivered it to our elected officials through a series of 7 regional meetings where we asked elected officials from municipalities that were served by a common EMS agency or EMS agencies to come together and meet as a group. The recognition being that the challenges that are affecting EMS agency A may be different than the challenges that are affecting EMS agency G. And we wanted to try to take an opportunity to get the elected officials from the jurisdictions being served by a specific agency all together in the same room with that agency. And in these discussions, we wanted to lay out some very clear caveats and previews about the presentation we were going to go through. First of all, there is no question. Some things that we'll talk about here are matters of opinion, and we'll try to be clear when we speak about things that are opinions, whose opinion that is, or how we arrived at that conclusion. But some things are matters of fact. And a matter of fact is that there are serious issues related to the assurance and availability of EMS in Berks County. Paul alluded to the failures that have taken place over the last number of years, and those failures have looked different in each specific circumstance. In some case, they resulted in a merger or a transition of an organization to another organization. In some cases, they resulted in literally a hole in the provision of EMS until another agency was willing or able to step in and fill that hole. What we know for certain is that the risk of other failures in both the short and long term are very real if we don't begin attempting to address these problems. We also recognize that the problems are complicated. It was not our intent that we would sit down at any of these regional meetings and on the back end of the meeting have solved the problem for the individual entities involved. Certainly that is not our belief in delivering this to the general public, that at the end of this hour and a half, we're going to say, well, geez, that's great news. We fixed something. Um, as I already mentioned, what affects EMS Agency A does not necessarily affect EMS Agency G. There are certainly commonalities, and where those commonalities exist, we do attempt to draw them out. But in some cases, agencies have financial problems. In other cases, the financial problems aren't nearly as great as the operational problems. So the solution for any given area of delivery is really going to be a unique and customized solution amongst the entities that are the services being provided for, generally the municipalities and the EMS agency or agencies providing that solution. And what we also recognize is that any long-term solution is going to require a lot of honesty, a lot of willingness to own part of the problem, if you will, and maybe an unprecedented degree of change among our local government systems and the need for unprecedented intergovernmental cooperation. I don't want to steal the thunder of the presentation, but as we go through, I think that some of you in the room that don't turn in the circles of local government, that are here as interested members of the citizenry, are going to be very surprised to find out how the legal system of delivery of these solutions is structured in Pennsylvania. Perhaps you'll even be a little bit aghast at finding out how the provision of these very critical services is structured in Pennsylvania. But what you will hopefully understand on the back end is that convolution and complexity speaks to some very difficult steps going forward to solve the problem. So, Chip, did you want to cover the background information?
Sure. We talked about, I think, enough about the failures, and we do know that there are other agencies that are clearly more vulnerable than others. I think the important thing from my perspective as a supervisor in Lower Heidelberg Township, it doesn't matter whether you're talking about a township, first class, second class, or a borough. There are the codes listed very clearly. It is the responsibility of the municipality you live in to provide EMS services to the residents that live in those municipalities. And once again, we talk about the county-wide issue. It's a statewide issue. It is a national issue. There's no question that this is not just unique to Berks County. And we're going to talk a little bit more in depth about how some other surrounding counties have come up with some solutions and some suggestions, and stuff that we need to also consider from our perspective. The other thing from a municipality perspective is that we realize through the Center for Excellence in Local Government, it's about intergovernmental cooperation. There needs to be a unified approach to solving this problem. One municipality can't provide funding when other municipalities that maybe use the same agency do not provide a similar or equitable line of funding. So this really is going to come back to a funding conversation initially as a short-term solution. And the immediate effort needs to be stop the bleeding and look at long-term strategies. The long-term strategies are dealing with the federal government and the state government as it relates to Medicare and Medicaid reimbursements. And Brian's going to talk a little bit about that in the up and coming slides.
Chip, just before we go on, one thing I want to draw some attention to is the second bullet about the municipal responsibility for the provision of EMS and what is in quotes there. And this is literally quoted out of each of these bodies of code, so it applies in all cases. The local governments are to provide for EMS by the means and to the extent determined by the local government as appropriate. So, I made this joke kind of at a number of the meetings, and I'll say the same thing here. In theory, if the township supervisors decide that the best provision of EMS in their local government area is 2 Girl Scouts and a box of Band-Aids who hang out on the town square, in theory, that local government has met their obligations, and that is a problem. When these codes were first introduced, when the changes to Title 53 that resulted in the in the codification of this requirement was there was much more stringent language. That language was removed by amendment, and this is what we were left with. And this is really part of the problem. What each of our local government bodies see as to the appropriate provision of these services. And again, we'll drill into that more as we go through this, but I just wanted to be sure to call out what the local governments are expected to do and what they're permitted to do in the provision of the services.
And there's a perfect example of where the public needs to be involved. If supervisors or elected officials are saying, you know what, we're not going to provide funding and expect other municipalities to cover that, or put a Girl Scout on a corner with a Band-Aid, as the public hears that, needs to be outcry, because that really is not acceptable, and nobody would want that to be the case. So we use that as an example, but more so to let people know that that example is not something that really is going to work moving forward.
So, Paul, I think traditionally you've spoken to the approach, if you want to cover that.
So we decided that it was important for us to go out and meet with each of our individual EMS providers. And in Berks County, Brian, refresh my memory, but I think there's 18 direct providers.
Correct. Depends on how you count them, those that are geographically located in the county versus those that are geographically located outside of the county, but have first due responsibility in the county.
So we reached out to each of the emergency groups and said, we need to meet with you and understand what's going on here. And in fact, we had individual meetings with all 18 groups. And we assured them that what we learned in those meetings were going to be confidential, but that we would share the information and just not attribute it to each of the agencies. So we met with all of them. And then we met, I think, 3 times with them gathered together at the Department of Emergency Services to address some of the things that we found. And it was very eye-opening. We thought, okay, we're going to meet with one and the same person, same problem is going to be the next agency, same problem, next agency. And what we found out is of the 18 different issues, there were probably 40 issues that were problematic to the 18 agencies. So they had 2 or 3 things that were problematic in a couple of cases. And so we met with them and we drew some conclusions off of that. And then we came back with them and said, these are some of the conclusions that we have, and we want to confirm that we're seeing this correct. And we found out that we were right on the target with it. So then we went out across the county and had 6 regional meetings with the municipalities, direct meetings where they came in. And in none of those cases do we have less than 30 attendees. In some cases, we had 50 attendees. So we felt really good about getting the message out, as well as the actual report itself. So one of the things that I think is really critical is that, you know, when we think about fire companies, we think about Ben Franklin, and he did the first fire company in Philadelphia. Well, I mean, that's 275 years ago. When we think about police, pretty much after the Civil War, police were a regular thing that were out here. When we think about ambulance services, they're really a product of the 60s and 70s. And it wasn't until we got into the 70s that you had pretty much uniform supply of ambulance service. And the other thing is that, you know, they are across the board in a bunch of different ways they're operating, and we'll talk about that. But just keep in mind that ambulance services are really a relatively new service provided to the citizens of the Commonwealth of Pennsylvania.
Okay, so we're going to step through some of the background information. Again, this was intended to help educate our local elected officials about how the EMS process works, because in many cases they don't know. They just know that they do whatever they do for their local ambulance, and when somebody calls 911, generally an ambulance comes, and usually it comes fairly promptly. But what they don't understand is the origin of these kinds of problems that affect our EMS providers, and clearly part and parcel of all of this is funding. So the page attributions that you see as we go through these slides refer back to the actual report that we published as a result of this effort, and Dave has assured us that that report is going to be distributed to everyone for review. But we'll attempt to cover the highlights of the sections as we go through the presentation here. So the number one biggest payer, if you will, to EMS agencies to support their operation is what we refer to as government payers. Medicare, Medicaid, all done through rules that are set forth by CMS. and Harrisburg in the case of Medicaid, as well as the Veterans Administration. These are by far the largest payers. These entities set the rules for how they pay. For those of you that aren't familiar with how insurance works, how medical insurance in general works, a lot of this has to do with why you see charges like, $3 for an aspirin tablet, because on the back end, the provider of that aspirin tablet really gets, 20 cents for it. Because Medicare and Medicaid at the state level, in whatever state it's being paid through, makes determinations about how much of the billed amount is really going to be paid through to the recipients. It truly is a matter of, he who has the gold makes the rules. It's very malleable. If there is a denial of a payment and the entity did something structurally deficient in how they submitted for the payment, they can certainly go back and resubmit and have the claim reconsidered. But at the end of the day, the money that they take is going to be the money that they're provided by the payer, and the recipient has very little to say about it. And I do apologize, I am in a working office, so I may have phone calls in the background that I'll shut off as quickly as I can. The next category is private insurance, and this is what many of us are familiar with. We either work or we own a business and we purchase our own insurance, and that private insurance pays to some extent. One of the really interesting points about private insurance is that most private insurance carriers, and when I say most, I really mean almost all, will not pay directly to the EMS agency. Unless the EMS agency has a contract with that private insurance carrier and has agreed to significantly reduced payments in exchange for their services, the private insurance carrier will only pay the patient, with the expectation then that the patient will satisfy the bill to the EMS provider. Interestingly, this has resulted in what we refer to in the EMS world as professional patients. These are people who have insurance, but perhaps don't have great financial wherewithal to pay their bills. In many cases, their credit is already in a bad place and they don't much care about somebody taking them to collections or reporting them for unpaid bills. And along comes the need to have a car insurance payment made this month. These people will actually call 911, summon an ambulance for a fairly benign thing that they will get an ambulance for, and we'll talk more about the expectation of the delivery of service later. But trust us for now that, if you call and say your toe hurts, no matter how ridiculous that sounds, if you want an ambulance will come. And if you demand to be taken to the emergency room, the ambulance will transport you. That will result in a bill that will ultimately go to your private insurance carrier. When the insurance carrier pays for that transport, that check is sent to you as the patient, and you can cash that check and make your car payment for this month. Now, obviously, the EMS agency is going to continue to try to pursue that billing and ultimately send you to collections. But if you already have poor credit, you likely don't care about that. And what you're really interested in is getting your car payment paid so that your car is not repossessed. In some cases, we have EMS agencies that know who these people are, and they will continue to respond to calls and transport the patient to the hospital, but will not bill the patient in an effort to stop this cycle of fraud, really, related to the refusal to disperse the payment ultimately to the EMS providers. The EMS agency has no say in this. If they're dispatched on the call and the patient wants to go to the hospital, they're required by state regulation to provide that service. And in reality, by not billing the patient, they're technically violating the rules for how this works, but they're doing it in a good faith way in an effort to ensure that or an effort to try to stop this cycle of fraud. The next category is subscriptions and contracted services, and we break these apart into two different things. In reality, this contracted services thing almost didn't exist 8 or 10 years ago. Ambulance services had subscription programs where they sent a fund drive letter out to all the houses in the community, and they said, hey, if you'll give us some reasonably small amount of money, in many cases we're talking $60, $75, $100 per household, if you ever need to use our services, we will then not come after you for the additional money that you owe us beyond what Medicare, Medicaid, or the private insurance carrier that you have pays. In essence, it was kind of a little micro insurance policy. The reason we lump these together is because in the last number of years, our EMS providers in some cases have partnered with our municipalities to try to get additional funding from the municipalities for the services that they're providing. And then what they do is they structure that in a system that looks very much like a subscription program. So in essence, the municipality pays some amount of money to the EMS agency. And that amount of money is broken out into a per household amount that looks very much like one of these subscription programs. And then the EMS agency says, well, in exchange for this, we'll in essence treat all of the residences within the municipality as though they have purchased a subscription, excuse me, under our subscription program. The next grouping is fund drives and donations. This is just literally money that good-hearted, civic-minded individuals are providing to the EMS organization as part of a fund drive or donation drive. It is increasingly smaller than it was in the past. In some cases, justifiably so, because the homeowner or the property owner is paying into the EMS organization indirectly through these tax dollars that we mentioned above in the contracted services. But in other cases, it's simply because people are generally not as willing or able to support community organizations through donations like they may have in the past. The next grouping is endowments, and as we go down the page, these become increasingly smaller. In some cases, our EMS agencies, which you'll learn are primarily private nonprofits, have historic endowments that help to fund their operation. In many cases, our EMS agencies that have these endowments find the endowment shrinking as they're dipping into them for operational needs versus capital needs, which was really the intention when they were created. And then finally, direct payments from patients. This is literally somebody got a bill and they write a check to the EMS organization because their insurance didn't cover it or they weren't eligible for a government payment. And they recognize that they owe a debt to an organization that provided them a service, and they write a check in order to pay that debt. This is very confusing for many people as they don't understand how the medical system works. They don't understand why they received the check from their insurance company and that they're supposed to be passing that check on, or why their insurance company is not paying the full amount of the bill that was sent to them by the EMS organization. It's just part of the general lack of understanding about civics and various related matters in our community that John Q. taxpayer suffers from. So this again is a summary of all the various means by which our EMS organizations are trying to find money to support their operations. And it naturally dovetails into this next slide, which is an effort to help you understand what the bills look like and what the actual payments to the providers look like. And we found during our interactions with very educated older, and I don't say that in the terms, many times people who are older are more experienced and wiser. So I guess the better way to say it is educated and wise government officials who had been around the block really didn't understand how when they got a bill for an ambulance run that was $1,700, that the ambulance wasn't like a cash register going down the highway, that every time it went out on the road, there was a $1,700 revenue realization being generated for that provider. So what we did was we broke it out into what we hoped was very common language. In the top part of the table here, the top subtable, if you will, is what is considered an ALS emergency. And you can think about this as a heart attack. The patient had a legitimate need. The need that they had was such that they required the highest level of care an ambulance provides to get them to the hospital. The middle subtable is a BLS emergency. Again, it was a legitimate emergency, a legitimate need, but not of the highest level necessary. An example, you broke your leg. Well, yeah, we got to get you to the hospital safely. You got to get that splinted, casted, whatever. But there really wasn't life-saving aid being provided in the ambulance. It was being provided at a lower level of care than that which is generally available. And then the final subtable is a BLS call that lacked medical necessity. And this is something, again, that most responsible people would be shocked to hear. The kinds of things that ambulances are called for, toothaches at 3 o'clock in the morning. Well, hospitals don't have dentists that are, you're not going to have your toothache fixed. Take an Advil, call your dentist in the morning and make an emergency appointment. Or somebody opens their mail and sees that their lab value report is out of the norm, and they call an ambulance to go to the hospital. Well, that's not a hospital. That's a follow-up with your family doctor. So these are the kind of things that can result in an EMS bill being generated and having different outcomes. So as we go back and look at each one of these, we kind of talked about the slide horizontally. Now we want to talk about it vertically or by column. And in the white column, the total amount billed is the bill that is created by the EMS organization by virtue of providing the transport that is indicated. The green column is what the EMS agency is almost guaranteed to get. And it's broken down in each subtable by whether you're a Medicare, Medicaid, private insurance, or private pay patient. So what you can see right out of the gates is even for the most urgent or most necessary EMS call in the top part of the table, that $1,700 bill by Medicare is knocked right down to a $434 bill. That is what the EMS agency is really likely to recover. The second column is the amount that is likely to be received from a secondary insurer if there is one. So in many cases, someone has Medicare, but then they have a Medicare supplement that is also providing against that. And then the red column is what the EMS organization must legally write off. They can't go after anybody for that. So again, we get to these Medicare and Medicaid payments. In exchange for receiving the Medicare and Medicaid payment, the EMS agency is precluded in many cases from pursuing the vast majority of that bill from the patient themselves. And then finally, we come down to the yellow column. And the yellow column is what the EMS agency can continue to try to go and get from the patient. But based on everything that I already described to you, the reality is they're not going to get that money in most cases. In fact, nationwide, the amount that is collected once we get to the point of having to bill the patient is about 30%. So 7 out of 10 of these bills are not even paid. Only 3 in 10 are actually paid by the patient to the ambulance provider to some extent. I'll take a quick pause there and ask Chip and Chuck if there's anything, or I'm sorry, Chip and Paul, if there's anything that they want to say about those funding case studies before we move on.
I would just like to add that Brian kind of talked about this process where if you're an ambulance provider and you take somebody to the hospital, the insurance company will give you a steeply discounted payment through the person who they provide their insurance to. If they pay it directly to the agency, though, it'll be even more discounted. And to me, it's unbelievable that an insurance company would say we're going to pay our patient $500 to take you for you taking to the hospital, but we have to pay you directly. We're only going to pay you $350. That just blows my mind, and it's part of a big problem we have with the insurance commission, where they don't even follow the things that they're required by law to follow because of the relationship they have with the insurance providers.
Yeah, I'll just point out to the fact that everybody, on this call could be a senior that has Medicare, could be you're managing your own personal insurance through your employer. You've seen the bills come across. You see how Capital Blue Cross, for example, discounts the bill on what the hospital gets paid. This is this whole process on steroids, meaning that we've all dealt with this problem and how the initial bill is much higher than what actually gets paid and what's covered by insurance, and then what's left to be balance billed or try to be collected. So this is just an example of trying to explain to you the complexity of how your potential normal insurance works for you personally versus how the agencies are trying to collect the money.
Great. So the next thing we want to talk about is kind of how EMS is delivered. And there is a little bit of variation in the county. Some of it has gone away as a result of one of those recent failures, but we're going to step through and talk about the various models of delivery of our agencies. Chip, do you want to cover that?
I'll do this. So obviously we're all aware of the two hospitals in the county, Tower Health and Reading Hospital and Lifeline Penn State, St. Joe's. So those are the two hospital-based providers. And I think one of the things that became very clear as we talked to these people individually, as we go through this list, we thought maybe we'd hear a different story depending on what type of model EMS services were being provided with. And it was unique that we once again heard things that we didn't expect to hear. And frankly, it is the word that potentially, the hospital systems would look to easily expand if there was a void in EMS providers. And Reading Hospital and Tower Health and Penn State St. Joe's made it very clear that is not their intention, not their goal. So we thought maybe that they would be some of the solution to filling some of these voids that would occur. But once again, as you all know what's in the news, they're all responding to their own crises with funding and hospitals going out of business or financial troubles. So the good news, bad news is you have some good solid hospitals and very, very fortunate to have these two excellent hospital systems in our county, but they're not the solution to solving the problem that is created there.
Chip, I would even go on to say, not only did they say it's not their goal, they said that they wouldn't have the capability, that where they could help, they would step up and provide services, but they don't have the wherewithal to just assume responsibility for vast amounts of coverage should another EMS provider go under.
Yep, absolutely correct. So then you move to the for-profits. Kutztown Ambulance there is now defunct. That was a for-profit ambulance service that was provided in the Kutztown area, and they just decided that the business was not sustainable. They retired, and the business pretty much went out of service. You then have other for-profits you'll see around the county. Typically, those are for-profit ambulances that simply do transports, hospital to doctor's offices, vice versa, or transporting people to a procedure or something like that. Those have different names on them. Could be Select, could be other agencies that you might see on the side of an ambulance. And once again, they typically do not provide emergency response like Kutztown Ambulance did at that point in time. You then have a very unique situation where the city of Reading is completely different than the rest of us. That's a municipal-based system that the city of Reading provides 100% of the funding through their fire department for municipal ambulance services. You then have the private nonprofits, which are the balance of the associations around the county. And those are typically standalone nonprofit agencies that rely on the funding as we talked about in the previous slide.
So just one other thing to mention about the municipal-based Chip so nobody walks away with a misunderstanding. When Chip says it's 100% municipal funded, that doesn't mean that they don't bill for their services. They still try to recover their revenue. They just provide this service in a way that people would generally think that government services are provided. We undertake the service, we provide it as efficiently as we can, and at as low a cost as we can to our taxpayers. But whatever the service costs to provide is what it costs to provide, and it's borne by the tax base. Then in the case of EMS, they're underwriting that cost by pursuing billing in the same way that any other EMS provider would, thereby hopefully further reducing that cost to the municipal taxpayers. But it is in reality, in all of Berks County, the only place where EMS is provided in the way that most taxpayers would customarily think that a municipal required service is in fact being provided. So there are other...
I think one thing we want to talk about also is, our model of delivery of emergency medical services is one that provides for mutual aid. So if you have an ambulance that's supposed to come from your municipality, but it's committed to another call, then Brian, through the 911 call center, calls out a separate agency to come and take you to the ambulance or to the hospital. And we're blessed to have a really solid system in Berks County, albeit strung as tightly as it can on a rubber band. But one of the things we found out was everybody's like, well, really, let's look and see who does all this mutual aid, and are there agencies that are taking advantage of other agencies? And the thing that really caught us off guard. Go ahead.
You're stealing our thunder, Paul.
Oh, I'm sorry. I'll stop then.
We're coming to that.
All right, cool. Sorry.
Okay. The other thing that kind of differentiates our EMS providers are these bullets here. Number one, are they paid or volunteer? And in most cases, volunteer EMS has gone by the wayside. There are a couple organizations in Berks County that still do have volunteers on the rosters, but in most cases, due to the amount of training and the regulatory environment, the concept of volunteer personnel has gone by the wayside, and most people who are involved in EMS are receiving some hourly rate to do so. Another consideration that comes into play is where our stations are located. It would be awesome if we could simply build EMS stations where there was population density and the call volume drivers that spoke to that. But the reality is that our EMS stations in almost all cases are wherever they are due to historic reasons. Someone, a good-hearted individual in the community donated some land, or there was a station was available when a Lions Club or some other community organization started an ambulance. And that means that our EMS stations are not really where they would be best built were we to be starting this from the ground up. Clearly, we don't believe that we can rip all of them down and undertake the CapEx cost of building all new stations, but it's an important consideration in understanding the inefficiencies of delivery of our system. Likewise, is unit deployment. Where do we have the most highly skilled providers in our ambulances? Where do we have lesser skilled providers? This gets into the level of service that we're going to talk about in a minute. But the reality is that we're not necessarily deploying the number of units or the level of care of those units in the best way. We're doing it in the way that we're able to do it given the resources that are available to us. Again, dovetailing into that level of service, we're going to use some terms as we go throughout here. ALS, you can just think about that as the highest level of care that an ambulance generally provides. There's a paramedic on board. They're able to do advanced procedures. BLS, or basic life support, I'm sorry, I should have mentioned ALS is advanced life support. BLS, or basic life support, generally a lower level of skill, no paramedic on the ambulance. They're limited in some of those more advanced skills, but they can provide stabilization of care until a paramedic unit gets there, or they can transport a lesser acuity patient to the hospital on their own. And then in the last about 7 years, Pennsylvania came out with a new level of care called ILS, or intermediate advanced life support. And IALS is exactly what it sounds like. It has a middle certified provider between an EMT and a paramedic called an advanced EMT. They're able to do some more skills than BLS, but not quite everything that ALS can do. Each of our EMS agencies are required to be licensed to provide one or more of these levels of care by the Pennsylvania State Department of Health. What's really important to understand, though, is an agency can be licensed to provide ALS care, but at any given time may not be able to offer that level of care due to availability of staffing. And staffing and personnel is another challenge that we're going to talk about as we go through here, but simply differentiating for now that there's a difference between the level of care an organization is licensed for and the level of care that they're offering at any given moment of time. And then finally, do they provide non-emergency services? When I think it was Chip talked about, Select or Romed, the for-profit ambulances that provide transport services. In many cases, what we generally think of as 911 ambulance associations, the ones that we're really focused on here that are providing emergency service in the community, also provide those non-emergency services. And this has been a matter of contention in some cases over the years with local governments who don't think that their EMS organization should provide these services. Listen, let me assure you that no EMS provider wakes up in the morning and says, ooh, another day taking somebody to kidney dialysis. These people are interested in serving the community, saving lives, doing big, important things. They're not interested in driving people back and forth from the nursing home to the doctor's office. But the reality is that these are critical services that have to be provided in our community. And if these organizations weren't providing them, where would the people that need the services get them? And equally important, these organizations that are providing the services are doing so because they're able to generate revenue in excess of their costs of providing for these services. And effectively, that is reducing then the amount of money that they have to be asking for from the local communities to provide the 911 service side of the house. So it really is a double-edged sword, but people should not view a quote 911 ambulance providing non-emergency services as a negative. It's something that they're doing that is necessary to keep the organization moving forward. We're going to talk about some of the specific challenges that our EMS organizations face in each of these areas, some with a greater level of detail than others. You want me to get started with that, Chip, on the provider last resort? So, as I mentioned, our EMS agencies don't have a say in whether they go. If they're dispatched, they must go. If they fail to go, they risk their license. There could be sanctions placed against them by the state regulatory agency, and in effect, that EMS organization could go away. Most people would be very surprised at the number of things that our EMS organizations are obligated to go and handle. Parents who have tween children acting out and decide that instead of better parenting, what they need is mental health services and call an ambulance to take their child to the hospital for mental health evaluations. People who don't have a primary care physician and just, I don't feel right. I'm feeling a little ill, something that most people would make an appointment with their doctor for. They'll call the ambulance to come and, quote, check them out. People who want to go to the emergency room for non-emergent conditions, and they understand that they're going to generate a bill from the emergency room, and they could clearly take a taxi cab there. But the difference is that a taxi cab is going to hold out their hand at the end of the trip and expect you to put $20 in it or whatever that taxi bill costs. And if you fail to do so, they're going to call the police and say that you're basically responsible for theft of services for not paying your taxi cab ride. An ambulance is going to take you to the hospital, and they're going to generate a $600 bill instead of a $20 bill. But the difference is nobody's going to expect you to pay it at the moment in time. They're going to bill you later, and it's a lot easier to walk away from that bill when somebody's not sitting in front of you with their hand out. So many other examples of where this applies, but the important walkaway is to recognize that EMS providers aren't taking people to the emergency room for left big toe pain because they think it's the right thing to do. They're taking those people to the emergency room because the people called 911 requesting the ambulance, and state law says that if the patient, and I put that in air quotes, if the patient requires transport to the ED, and requires means requests or desires, the EMS agency must satisfy that transport request.
Let me take the capital funding bullet point. This is one of the things that we learned with our individual meetings with the agencies, something that was very disturbing. Imagine you're running your company and your daily operational costs are not being funded by your revenue or the funds you're collecting for service, and you've got to dip into your capital reserve or savings to fund your operations. We found that to be the case in a bunch of situations with the current providers throughout the county. Imagine on the personal level, if your paycheck does not meet your rent payment or your utilities payment, and you got to dip into your savings account every month to make your bills fundable. Part of the problem is that if you look at the cost of an ambulance these days, it's $100,000 to $150,000 just to outfit the ambulance itself. So you got to buy the body, the chassis, and then spend $150,000. That's covered by the litter. That's covered by the heart monitor, all the different stuff that goes inside that box that responds to you in a time of emergency. You can't have expenditures like that that are capital intensive that aren't funded somehow. And when we're having agencies spending capital dollars to fund operations, you can imagine that's not going to last very long. So that's the house of cards, frankly, that the model is kind of built on right now, and it's very concerning. It doesn't matter whether you're talking about a fire department. I mean, the cost of fire engines these days, ladder trucks are through the roof. The ambulance is faced with the same situation. The police department's the same way. The difference is your police department and typically your fire department are funded through municipal run organizations. We have their budget. We're aware of that budget in a lot of cases. On the EMS side, these are separate organizations where we do not have access unless they're giving us that information voluntarily on how they're doing financially. And that's one of the things we drove home to the elected officials. We said, you guys have got to be aware of how these agencies are doing individually financially, because you're being asked to give more money to help fund this gap. And that money is really stopping the bleeding, but at the same time, we're spending capital dollars. Just real quickly on personnel, this is not unlike any other situation that we're dealing with across this whole country and world these days. It's a matter of understand the pay rate that these people are getting paid. Nowhere near what fire personnel are being paid, nowhere near what police officers are being paid. It's a much lesser pay rate than what you see on other professional emergency services. And part of the problem is, in order to make a decent wage, some of these people are working multiple jobs through multiple agencies in order to make enough money to make payment on their own personal bills. We've certainly, as one of our recommendations, have talked about a need for a personnel study looking at rates and funding rates and things like that. I don't know that I want to go into that today, but if you realize that you can really go to McDonald's or a Wawa and make very similar money as you can at a starting position as a BLS provider in an ambulance. And that's not right. I mean, these people are providing emergency services to us, and they need to get paid a little bit higher than what they're getting paid now. And that's one of the other issues we have. They don't have enough money to provide operational services, but yet the funding for personnel is very much a disparity. Now, once again, there's a difference. Once again, not one size fits all. The hospitals are paying a little bit more than the nonprofits. The city of Reading's paying a little bit more because they're on the same structure of payment as their firefighters. So it's not the same depending on who you're talking about. So when I say that there's disparity in how these people are being paid, it's not across the board. I want to just clarify that. Anything else I missed there, Brian?
Also, yeah, it's also worthy to mention, Chip, that beyond raw pay is benefits, and in many cases, people that work in the government sector, they may not be paid equitable to folks in the private sector who have similar jobs, similar training, similar responsibility. But often in the public sector, the benefits are better. There's a public pension. Because these folks, by and large, are working for private nonprofits, they don't realize those same benefits that, for example, a police officer would see who is truly a municipal government employee. So not only are they not getting the pay, they're also not getting the customary benefits that are seen in emergency services and public safety roles. And that's resulting in them having to, in many cases, work multiple full-time jobs. There are people who are literally going from one EMS job to another EMS job, working back-to-back 12-hour shifts because that's what's necessary for them to support their family at the pay rates that are available in this particular field. Now, clearly that's bad for the folks that work in the field. It's even worse for the ability to recruit into the field when you're trying to get someone to pay to go to school, with that being the back end that they can look forward to. And this has created a significant problem across all of our EMS agencies, and goes back to what I said about the provision of care. You're licensed for ALS, but at any given time, you only have a BLS ambulance in service because there simply are not enough certified providers out there in the world or coming up in the pipeline to be able to staff these trucks. This is one of the biggest realities that we have to deal with in this discussion. This is not just a here and now problem. If we're not able to turn a corner in 3 to 5 years, I don't know where we are, because we're not bringing people into the system at the same rate that people are going out of the system. And the system today is already in bad shape in this regard. So the next item, unit depletion and cost of readiness. One of the important things to realize is that the cost of an ambulance is not when it's driving down the road. The cost is to have the ambulance available in case it needs to drive down the road. And because the reimbursement model is a transport reimbursement model, if you have a statistically weird shift where you go for 4 or 6 hours without a call, you still have 4 to 6 hours of all of the expenses of maintaining and operating an ambulance, but you didn't generate any revenue because you didn't do any transports. In the fire service, we look at that as a positive. We say, well, it's great. We paid for firemen and we paid for a fire truck, and they didn't have to go out and put somebody's house fire out. We don't expect that fire truck to go put fires out to generate revenue to be available for the next fire. Yet in the EMS world, this is how the system is built. We expect them to be going and doing their job in order to be able to generate the money to do their job the next day. And it is just not a system of funding that is conducive to an emergency services model, where what we all as taxpayers really hope is that the system never gets used, because every time the system gets used, it's a bad thing for somebody. And in EMS, we simply, for some reason, don't look at it in that same way. Unit depletion gets into some of the stuff that Paul was talking about, and I'll defer back to him in the mutual aid discussions now.
So we have to make sure that we have ambulances on duty. And if an agency says they're going to have 4 ambulances on duty and they only have 3, then that stretches the way they can serve their area. And what we found out, which is really interesting, is that the balance of mutual aid in Berks County is very fair. There's one agency that receives a lot more support than they give, but the one that really surprised us was the city of Reading. City of Reading, they staff 4 paramedic trucks every day, unless something happens and they lose the personnel. But they send their vehicles outside of the city as much as other agencies send their vehicles into the city. I think a lot of people think of the city and it's just a drain of services, but the opposite is absolutely the case. These are the highest trained personnel, and they're leaving the city as much as anybody coming into the city. So that was a very insightful look that Brian was able to pull up based on the calls that we had and where people were sent. So that was a big deal. When you look at that insurance bill that says $1,200 and they're only paying $340, because the insurance company is only paying for that transport of that patient, but the ambulance has to have people staffed there. We have situations in the northern tier of Pennsylvania where they're running off of volunteer ambulance people. So you get a call for an ambulance, it takes them 10 minutes to get to the station, to then pull the ambulance out to get you, to take you to a hospital that may not even be in the county you're in. And so an hour and a half later, you finally get to the county, or get to the hospital. We don't have that issue quite as bad here in Berks County, but it's on the horizon, and we have to be able to provide the ability to have readiness available for our ambulances.
And Paul speaks to a 10-minute delay until the ambulance personnel are there and ready to go on the call. The truth is that in many cases it's even longer than that. I'm not going to name the county, but in one of the counties in northeastern Pennsylvania, in a very sizable county, very similar to Berks County, there is a lawsuit that is currently underway over the fact that ambulances are taking 30 to 40 minutes to respond. That doesn't mean from dispatch to get on location. It means until an ambulance actually is on the street going, because they're dispatching an ambulance. The ambulance is failing to respond. They wait a reasonable amount of time to see if it responds. They dispatch the next ambulance, and they're going through 3 or 4 ambulance services until someone actually comes out and takes the call. We are super fortunate in Berks County that we don't experience that kind of a problem, but it is being experienced in Pennsylvania and in similarly sized counties to Berks County.
The other thing I'll mention is that we are seeing, at least in my township, that the fire department is being called if an ambulance is not available. That's at least to provide some quick response treatment and anticipation of the ambulance finally showing up. We're very fortunate that our fire department has agreed to do that. There's other fire departments that have said that they can't afford to do it or don't have trained personnel to do that. So we want to talk about that, and I think it's important to understand that the agencies in general, police, fire, ambulance, are trying to work together to provide the highest level of service. But this cost of readiness, unit deployment, is a big issue for sure.
So, Chip, one thing I want to mention, just because we're dealing with a citizen level audience here who may not understand the terminology, you said that the fire department goes when an ambulance isn't available. I just want to make clear to everybody that what we really mean is when that first due ambulance, the normal ambulance that you would get, is tied up on another call. There's always going to be an ambulance available. It's just a question of how far is it having to come from. And what Chip's driving at is that generally if it's second, third, or beyond due, the fire department goes to begin to render care, stabilize the patient, recognizing that the ambulance may be coming from that further distance. It's not that they're technically not available.
Correct. Thank you for that. That moves us right into the reporting. I talked a little bit about that. And once again, as municipal elected officials, we're getting asked to, fill the funding gap. And what we made very clear is that, we're okay to look at considering additional funding. However, we need to be informed of the financial situation of all these different agencies that are asking for more money. It's like, yeah, we all are watching the TV these days, and it's about Elon Musk and Doge. It's efficiency. And once again, if we're being asked as elected officials to fund additional monies to agencies, we want to make sure that there's efficiency and that we're operating at the best level we can possibly do that. So we pretty much have pretty much said that, hey, not a problem. You want more money? Give us some information, support the need, and that's something we can certainly consider, I think, as we look at more funding here.
Chip, you want to talk about the executive leadership bullet too?
Sure, I can do that. What became also apparent as we met with these individual agencies is the executive leadership for these agencies are not equal. There are some agencies that have really good qualified leaders and are geared towards a management style. And in some cases, some of these leaders in these agencies are paramedics that have been there long enough, that know enough about the business, that were promoted to leadership. And they're really more providers, very, very knowledgeable, but maybe not business sense related to operation and understanding the budgeting and efficiencies and control. So we saw a vast difference in leadership levels amongst the organizations that we spoke to. And that's something that is something that we have identified as something that we need to fix somehow, some way.
And I think it's important to note that this isn't being talked about kind of behind their backs. In some cases, these leaders came to these meetings that we had and said, listen, I want to be honest with you. I'm a great paramedic. I've been doing this for 20 years. If you need help in the back of the ambulance, there's nobody you'd rather have than me. But I've never had business classes. Nobody ever formally showed me how to do these things. I just got promoted into this position and I'm doing the best that I can, but I really need some help. There would be value if there was a mentor that I could work with that would help me to understand these things. And in some cases, this is because, again, back in the beginning of these organizations where there were boards of directors of community organizations, we had those types of folks on the board and they were more involved in the operation of the organization. And they were local business people and officials who mentored the staff in those days, maybe even volunteer staff, and how to do this. That's really very much gone by the wayside in most organizations. The boards are, for lack of a better term, rubber stamps. They might have a monthly board meeting, but they're really not up to their eyeballs in the operation of the organization or providing mentorship for the operational managers that are running the place. So the final thing that we want to mention is interagency cooperation, and what we found. If you're the individual who needs help, and two ambulances with different names painted on the side of them come to assist you, you should have no concerns about the kind of care you're being provided. Out there on the street, these folks are working in lockstep. They're partners with each other. There's no professional jealousy, no egos involved in the provision of patient care. But the truth of the matter is that due to no fault of their own, the system that they work in causes them to be business competitors. And that means that they're generally not willing to show all of their cards to each other out of fear that the neighbor might try to exploit information that they get. So as closely as they work together on the street in the provision of the actual services, on the back side of the operation, the business side, for lack of a better term, in many cases, they're resistant to working together and sharing information with each other about challenges that they're having, or asking their neighbors to support them or do things for them, for fear that effectively puts blood in the water and results in people seeing that weakness and trying to take advantage of it. Anything else you want to say with that, Chip?
Yeah, one of the things that we spoke about was, for example, we spoke about unit deployment and the deletion of units when somebody just doesn't have the personnel to put a paramedic unit on the street. We talked about the importance of them communicating amongst themselves to say, hey, if X agency doesn't have an ambulance available for paramedic services, could the other agency, neighboring agency, upstaff to cover that gap? And we were assured that conversation is occurring in most cases. So there is friendly conversations that are occurring amongst agencies to understand staffing needs and potentially upstaffing if one agency could not provide service.
So the next portion of the presentation talks about the conclusions or findings of this report. And again, these PowerPoint slides in our discussion are intended to be a high-level overview. I'm super hopeful that the folks that had enough interest to participate in the presentation today will also have the interest to read the actual report document when they get it, because there's a lot of back detail that justifies or supports the conclusions that were arrived at that I think would be lost if you don't take advantage of a review of the report. We also want to go through these kind of quickly because we want to make sure that there is time for discussion or comments on the back end if Dave has collected any of that. So the first action item that we talk about is mutual aid. And GIS is Geographic Information Systems. It's basically the use of mapping to assist in dispatching. It's our belief that if we understood where our ambulances were in the field, we could make better decisions about which ambulance to send. And there's always a dialogue and an argument about, do you get your home ambulance? I would argue that if you're the person having the heart attack or the person who broke their leg or whatever, you want whatever ambulance is going to be able to get there and provide you care most efficiently and most competently. And because the state regulates the delivery of EMS, unlike the fire service, which is effectively unregulated, that means that by and large, an ambulance and crew of a given care type, an ALS ambulance and crew, should be pretty much the same as the next ALS ambulance and crew. And therefore, it really comes down to proximity and distance to response. This is a contentious matter, but the finding of the report is that we really should be using closest unit dispatching in the vast majority of cases. Chip already talked about staffing schedules and sharing. There are examples, as he mentioned, where that goes on, but there is no universal sharing of that. Sometimes an EMS manager doesn't have the ability to prepare for and plan for having to run extra calls, and therefore maybe needing to bring another crew into service because their neighbor's going to be downgraded in level of care or out of service. If there was sharing of that information as early as possible, the possibility exists that other EMS agencies could be more agile and work to fill the holes that would otherwise be created. And also, the report found that the county, meaning the Department of Emergency Services and the EMS provider, should work together to modify dispatching models to incorporate the primary dispatch of those intermediate ALS units that I talked about, as well as what are referred to as non-transporter squad units. So this isn't a conventional ambulance. This is a single provider, generally in an SUV, that is bringing ALS gear and capability to a call and partnering up with a BLS transport ambulance to better stretch the availability of our limited ALS personnel. On a good news front, this third bullet is very much already accomplished. We, meaning the county and the EMS providers together, took this very seriously and worked through the process. And as of the middle of February, we are utilizing these IALS dispatches, and we'll continue to evaluate that as we move forward to see if it can be improved upon further. Paul, I think you generally talk about the training piece and the importance of our local governments and understanding the need for training.
Happy to. So, it used to be that you could get EMS training on whether it is just as an EMT or an advanced EMT or a paramedic, and you could pick it and you could do it. They don't exist anymore. There is very limited educational opportunities for staff people to actually go in and improve themselves or even become the entry level EMT. So one of our recommendations is we really have to work with the colleges and universities and our local officials to put aside money to make sure that we can run regular training for these individuals. And in particular, if you're going to the paramedic level, it takes a lot of education there. And so in an area that really is stretched right now, you're taking your advanced EMTs and you're taking them out of service because they have to do their training for paramedic, and they can't even be on the job, which stretches the system even further. So we want to make sure that one of the things we look at is how can we look at the 5 colleges and universities that are in Berks County to support a better process of providing training for these individuals. Compensation is a huge issue. You know, when we look at our municipalities, if you have a police department, some of the lowest paid police departments in Berks County start policemen at $55,000-$60,000. That's the top number for a paramedic. And when those police officers start, they get pay, they get vacation, they get pensions, they get support. A lot of the people working for EMS in Berks County, they get paid. That's it, and they can't even work overtime because the agency can't afford to pay them. So they have to work for other agencies. So you work 40 hours for your base agency, and then you go work for another agency for 20, 35 hours a week just so you can get additional pay. So one of the things we have to work on is really understanding where this pay should be. Paid firemen in the county are at $80,000, but we're looking at these nonprofits paying their personnel because of the lack of funding at a level that just means that they're going to work 5 or 6 years in the field and then look to go somewhere else. They just cannot afford to raise a family on the pay that they're going to get and then be absent in that family because they have to work so many jobs to raise it. So that's part of our report is that we've got to look at this whole issue of compensation and benefits and bring these individuals into an area where there is an opportunity for at least a partial career, if not a full career. The other problem that we have is, and I think either Chip or Brian alluded to it, we have some really good paramedics that operate in the county. And guess what? They stop being paramedics because if they get promoted to be the director for the agency, they work less hours and their job is less stressful. So we lose these people to the leadership of their organization as opposed to running the ambulance and providing the service. I think with that, I can just pass it on to the next section.
Yeah, just one thing to mention with that, Paul, that's an interesting statistic. So we have 1,056 certified EMS providers who reside in Berks County, but only 428 providers whose names were on what we refer to as a PCR or a trip sheet, meaning that they were involved in the transport of a patient in the year of data that we looked at. So that's 40.5% of the people who are certified to work in EMS are actually providing those services. They either have that certification and have moved on to a role in a hospital, or they're in an administrative role, or perhaps they're a firefighter who's even a volunteer and merely has this information or this education because it benefits what they do for the community in that regard, but they really aren't providing EMS service. In many cases, these people are providing these services in other counties, particularly to the southeast of us, because the pay rates are significantly higher, and it makes that miserable commute actually worthwhile given the difference in money that they can make.
The one thing I think we should mention, Brian and Paul, is that the training that is available in Berks County is Tower Health. The School of Nursing is providing paramedic training, and Muhlenberg Ambulance has a basic life support training. So there are some providers in the county, but not enough, certainly.
And I will drop a bomb on you, Chip. In the last week, Muhlenberg Ambulance's program has been credentialed to provide advanced EMT training now also.
Oh, fantastic.
Yep.
Good. Congratulations.
Okay. So again, we're going to try to move through these a little quickly. We want to leave time at the end. Funding. So Chip, I'd like you to talk about this because you're the one that's talked about the lobbying efforts and things like that.
Right. You know what it's going to take to change regulations in Harrisburg and in Washington, D.C. Part of the problem is we don't have the horsepower, certainly here as the Center for Excellence in Local Government, concentrated on Berks County to do this. We're relying on and have to rely on things like the Boroughs Association, the Township Commissioners Association. I'm sorry, the Township Commissioners Association, PSATs, or the County Commissioners Association, statewide agencies that would have the horsepower to come together. The ambulance associations have a group that they function under. So we've got to rely on bigger organizations that have the horsepower to fight these regulations for campaign to educate the federal and state elected officials to talk about the lack of consistent funding from the programs we talked about on the front end of the program. Each municipal area has got to establish an appropriate subscription amount. Here's where there's huge differentiations between how we're funding these agencies. I can tell you on our case, we're providing a very large donation to the ambulance association that serves my township, but yet there's other municipalities that don't give them pretty much anything. I mean, we're talking about $100 to $500 compared to other townships and things like that. They're providing the huge amount of funding. So there's got to be some action taken where these municipalities come together and say, hey, listen, we're not going to be funding this organization for you when you're not contributing anything. So there's a big variance on how these groups are funded. And the problem is that no matter what, if you're not getting funding from a borough or a small township, you call an ambulance, the ambulance is going to has to show up there. So it's not like we can withhold. So, sorry, you didn't give us any money. We're not going to respond to a call. We don't have a choice. So it's a very slippery slope. And it's almost to the point now where I've talked publicly about shaming people and publicly talking about where the funding's coming from, because certain Berks County residents are paying a lot more through taxes than others. And that's a big problem we've got to kind of wrestle with.
These other two bullets really roll right back up into that second bullet and get to what Chip's talking about, the need for an equitable system of funding. As equitable as it can be, given the bizarre system of government that we have here in Pennsylvania and how different it is than most other states in the United States. Clearly, it can never be accurate down to the penny, but the reality is that the average homeowner in XYZ Township should be paying very similarly to the average homeowner in ABC Township, because as we've talked about here, this is a guarantee of service. And I just want to really drive home what Chip said. There are municipalities in this county that are providing $250,000 a year to their EMS organization in funding, while another municipality who is being provided service by the exact same EMS organization is literally paying $500 or $1,000 a year in the form of a donation. That is completely unreasonable. It can't continue to go on. Even if we're not worried about EMS and keeping the EMS system afloat, just the distribution of cost is unreasonable. Even if in aggregate, EMS as a whole is not going to get one more dollar out of our government entities, simply how the existing dollars are being distributed and broken out across the taxpayer base needs to be fixed and addressed. And I will take 5 seconds to say this very similar problem exists in the fire service also. We have municipalities that contribute significant money for the availability of firefighting operations, while other municipalities are in essence leaning on those operations to get their services, but not contributing anywhere close to an equitable amount of money.
And unlike the police department is another one. There are certain municipalities and boroughs that choosing not to have their own police department, that rely on the Pennsylvania State Police to respond. Okay, well, guess what? You're going to wait a little bit longer for a state trooper to show up to an emergency call than you would if you had your own police department. On the emergency medical side, is that what you really would like to see? Say, you know what, we'll rely on the ambulance to come from Harrisburg because you're not funding your local agency. So this is a huge problem. It's governed by law. There is no getting out of this, but yet it's really not fair to the municipality you live in that is providing the service and the funding.
So as we approach 10 of the hour, guys, I'm going to make an executive decision here to very much gloss through this slide, mostly because it's very dry material, and can really be summarized in saying that the group that did this study recognized that the EMS providers have a role in this too. Kind of like Chip said in the beginning, if they're going to get some more local government dollars, they really need to be stepping up and providing a more comprehensive degree of reporting. Even though they're not a department of the local government, they should be expected to provide similar reporting to what the public works director or the police chief or any other department head / official of that government organization would be expected to provide. And they also need to provide that information in a timely fashion. You can't come to the local government on December 30th and say, hey, we're in really bad straits. You need to cough up more money. There's a local government funding cycle. There's budgeting that is done. Most local governments are advertising and approving their budgets in November or December for the following year. That means that these types of requests have to come in well in advance of that so they can be baked into that process. And this was really pressed hard on our EMS managers managers, although some were already doing this and participating very much so in their local government process. The ones that weren't, we said to them, look, you can live on the outside edge of the envelope if you're able to stand on your own. But the more you're putting your hand out and asking for help to provide these services, the more you have to be willing to participate in the administration of that process in a way that is customary for a local government organization. Before we move on from that, Chip and Paul, anything else we want to say about reporting?
I think we're good, Brian.
Okay.
Good to go.
And then the last thing we wanted to mention as a result of these findings is the concept of agency consolidation. As we talked about this, one of the things that we recognized is that many times when people see problems in government, their answer is, we'll get rid of some of it. Consolidate the organizations, get rid of the weak ones and get us down to 2 or 3 organizations. We hope that everyone who participated in this and who reviews the report recognizes that while there may be opportunities for consolidation, that's not the sole answer. There's still X number of EMS providers. And as Chip mentioned, if I'm an EMS provider that works for 2 or 3 different organizations, and those 2 or 3 organizations consolidate into one, I now can't work for 2 or 3 anymore. I can only work my 40 hours under federal law. And then beyond that, you're obligated to pay me overtime, which many organizations can't afford. So while that might be great for the EMS provider, the reality is it could cripple the system of delivery because we need X number of person hours of butts and ambulance seats to be able to deliver the service throughout the county. And if suddenly somebody who is willing to climb in the cab of an ambulance and do the work can't do it because of labor law issues, that's that many hours of staffing that now we have to figure out how we're going to provide, given the fact that we don't have anywhere close to an unlimited number of providers able and willing to provide this service. So we hope that people see that consolidation is not the sole answer. There are definitely opportunities for cooperation, some of which are called outbilling, purchasing, scheduling. Our ambulance service providers could work together more closely to create efficiencies in those areas, but we shouldn't preordain or believe that the final solution of this is a smaller number of EMS organizations. It may actually not be in anyone's best interest. So where that took us to were the steps that were immediately to be had on the conclusion of the report. Number one, the regional meetings. We mentioned that we've had those, and now we're opening this up to more public-facing environments like the ones that we like today. The recognition that there is no short-term solution to this other than money. And I think that I don't want to turn out anybody's political card here for Chip or Paul, but I think that the 3 of us over a beer would all talk and consider ourselves to be fiscally conservative. We're not people who think that the answer to government is spend more taxpayer dollars and raise taxes. But we also believe that for this particular challenge, we cannot afford to lose EMS agencies in the short term while we're looking at a longer term solution. And the unfortunate reality is that while we can redistribute costs in the way that we talked about and making sure that municipalities are stepping up equally, the short-term solution has got to be to put money in the hole in the dam in order to keep our EMS organizations afloat while we're working through these other bigger picture and longer term challenges. We believe that there needs to be a strategic look at how EMS is delivered throughout the county. And we need to do this in a different way that is more efficient and better for the delivery system itself while reducing additional costs to the taxpayers. The county commissioners, although they recognize that third-class county code gives them no role in the provision of these services, is enabled by county code to provide grant dollars and to provide supportive mechanisms for our local governments. And they have indicated a willingness to fund the development of this strategic plan if our local governments and EMS organizations volunteer that they are on board and within reason are willing to undertake what the strategic plan says needs to be done. That's kind of the step that we're at right now. We're collecting that input from the local governments now that they've seen the presentation. And if that input indicates that that desire is there, we are pretty confident that the county commissioners are going to help us through to that next step of developing that strategic plan. So that obviously represents a lobbying opportunity for those of you that are on the call today as local citizens or taxpayers to understand where to go to lobby your local and county government to help to fix these problems.
And
Chip, Paul, anything else you wanna-
that's exactly the ask. This is like I said, this is the first meeting we're going public with this study. And that the request from me directly to the public is you've got to get involved with your local elected officials, local county officials, and say, hey, there's a problem that we need to make sure that everybody understands is out there. And we've got to understand that once again, these local elected officials need to agree that things need to change for sure. And that's what I need you to do. Thanks for listening.
So Dave, with your permission, I'm going to stop sharing if you're ready to go to the chat and any questions or dialogue.
Yep, we're ready to go. Thank you, guys. A very, very engaging and informative conversation. A bunch of questions. What reaction have you gotten so far from the local government officials?
It
Is
was
it been
very,
positive?
very positively received. There's no question that the people that attended the regional meetings typically understood the problem. I would say there, without a doubt, there are examples all across the county where local government has imposed a $500,000 EMS tax that's available. Other people have gone ahead and increased their contribution, even though it's not tax coming out of the general fund. So we've seen absolutely some increase from some municipalities on trying to level out the funding. Is it completely solved? Absolutely not. But absolutely, you know, once again, there are, you know, if you think about townships and boroughs, 7 borough councilmen, we talk about, you know, 5 or 7 township supervisors. You know, once again, there's a lot of elected officials out there, and the problem is it's going to take the majority of the local municipality to agree to do this. And once again, we're all worried about increasing taxes. The taxes are under pressure on every aspect of municipal budgeting these days. Nobody wants to raise taxes because we're all being forced to live with the inflation and the problem of cost of living. Last thing we want to do is raise taxes, but this is a situation where I'm not sure you have an alternative on the short term.
How much money are you looking for the county to put on the table?
I don't think we know the answer to what it's going to cost, Dave. I think that the reality is that we're going to have to develop an RFP that we solicit input from third-party consultants, evaluate what their capabilities are. Again, the county, I'm speaking for the county commissioners to some extent here, and I rarely do that except where I think I really know their view and opinion. And we've had some dialogue. The county does not want to impose this on the local governments. They understand these are not their horses to whip. It is the local government's plural obligation to step up and make the ask to the county for how far they want to go, what they want to do, and that's what CLG is in the process of developing a survey instrument in order to collect that information. Is that correct, Paul?
Yes,
Correct.
exactly right.
So is it possible that the county money could also be used to foster that interagency cooperation that you thought was so important, to get the different groups to work together?
Well, I mean, I guess I'm not going to say no, but I guess we would hope that we wouldn't have to pay people to work together in a process that is a mutual interest to them. You would hope that they would recognize the need to have that cooperation be a part of the solution and not. I understand that government frequently does social engineering through money. How does the government get people or other government units to do what they want them to do? They make money available and they make a contingent on that. This is a place where I would really hope we wouldn't have to do that. I would hope that we could get people to work together because they share a vested interest in the provision of the service.
No, that makes sense. I'm going to ask you to go back a couple steps. What type of credentials do the EMS providers need? You said that we don't have enough of them being trained, and enough of the ones who are trained aren't doing the service.
So a basic EMT class is about a 6-month commitment of multiple nights during the week as well as weekends that includes both didactic training as well as practical training, and then time on the street actually mentoring on an ambulance in order to be signed off on your skills. That when I took that program in 1990, that program cost me $75 and it includes the book. That program today is well north of $1,000. So imagine asking somebody to make that time and money commitment without a real clear picture on the back end of a career opportunity.
Right.
Many people are just not able to do that. A paramedic program, depending on where you go, can be a year to a 2-year program, many more hours, and many thousands of dollars to take the program in order to be certified on the back end. And one of the things that we recognize, and we talked about this with the local officials, but we glossed over a little here, is that even where we have programs, Chip mentioned that the Tower Health, the Reading Hospital School of Health Sciences has a paramedic program, and it's a great program. They have an awesome success rate of people coming out of the program, passing their national certifications, becoming certified providers, but it's kind of a one-size-fits-all. And the reality is that unless you're able to do that almost full time, you can't transition into that. I can't work a full-time job and also go to paramedic school in the hopes of advancing myself. I almost have to commit to school in a full-time capacity. So not only do we want to support our training institutions, we also want to diversify them and create opportunities for people to get this training in different ways than what is currently available to them today.
So I'm involved with the Workforce Development Board and some of the stuff that they're working on their strategic plan. One of the areas they're focusing on is the area of healthcare. This might be a good area to have a conversation with the Workforce Development Board and have them talk to the education providers in the county to figure out how to resolve some of this challenge.
Absolutely. I think, to coin the phrase, it takes a village. I mean, we recognize going into this that Chip and Paul are not going to solve this problem. They can be the voices, they can be the catalyst, but we're going to have to bring other government entities and other pseudo-governmental organizations, like you talked about the Workforce Development Board, to the table to get these solutions to be implemented.
There is absolutely conversations occurring on cooperation. For example, you're aware of multiple municipalities that have combined fire service, combined police departments. There's conversation about that happening on the EMS side. There are examples in Lancaster County where they created an authority that typically has comes together with municipalities that want to join the authority, and that's a funding model. There's been some legal pushback on that, but the PMAA, Pennsylvania Municipal Authorities Association, is supporting the EMS agencies on creating an authority. So I do know on our case, we are talking with our surrounding municipalities about how we can come together and do this through a cooperation type of agreement. We're gonna have to walk on this before we run on this, but
Right.
starting an authority, getting municipalities to come together or agree is the very difficult situation to do initially, but you got to start small and then go larger. Ideally, should it be a county-wide authority that does this? Sure, that would be an ultimate goal. Not happen in the short term, I'll tell you that. We can't get everybody to agree to give some funding level, let alone agree to the authority model.
We are significantly ahead of a lot of the counties, especially the ones that are in the size that we are, as opposed to the more rural counties, in that we've gotten this information from the many EMS providers that we have in the county. A lot of the other counties that are doing this, I mean, they're starting from scratch. They have no basic information. They have no understanding of what their services are like. But one of the issues that we have is that we have 72 municipalities and we have 18 EMS providers. So the solution, I'd love to say, we've heard it, I'd love to say, wave the wand and the solution is there. It's not. It's going to be 10 different solutions for 10 different issues. And we have to try to find that common ground that allows our municipalities to say, okay, we can support this, we can do this, we can do that, we can do this. And then ultimately, over a period of a couple of years, we are able to prop up the EMS service to the point that we can then now provide the solutions that make it be a long-term solution.
So we have sort of reached our stopping point, but I want to ask each one of you to tell me in just a couple brief sentences, what do you want the people watching this to do? What's the two most important things that each one of you thinks they could do? Start with you, Chip.
We need to spread the word. Once again, this needs to be a grassroots effort to start with all your local elected officials, county officials. If you're friends with state legislators or senators on the state level, the state has increased their Medicaid funding. That was something that recently happened. So we've seen a big increase with that. We all know the federal government and the struggles with Medicare, but spread the word. Use this as an opportunity to talk to your neighbors, any organization you're part of, any business you're part of. This needs to be raised at the highest level, and we need to get the word out to the elected officials to pay attention. We've raised this with them, but now we need to go down to a grassroots approach to trying to solve the problem.
Brian, your answer.
I'm certainly not going to say my answer is better than Chip's or should take precedent, but I'm going to give different ones. Number one, I understand from Dave that many of the folks on this call are they're not involved in government. They're just prominent folks in the community that have an interest in what we're doing. And if that is in fact true, I would ask you to reach out to your local EMS organization. Find out who it is. Ask them if you can get involved. And that doesn't mean you have to ride in an ambulance and be a paramedic. If you're a mechanic and you know how to help them work on trucks, or you're good at plumbing and can fix the sink for them, help to save them money that way. This is the same thing we encourage in the fire service. We need firefighters, but not everybody that can participate needs to be a firefighter. There are ways to help with those organizations, and particularly those of you that have experience or business people, things like that. Go introduce yourself to your EMS chief, offer the skill set that you have, and let them know that there are people out there that are able and willing to help them in these things that are secondary to the actual provision of EMS care.
And Paul, your answer.
I think we need to talk about this, not only to your local elected officials, but to your neighbors. People need to understand that there's going to come a time when you're going to call for the ambulance and it's not going to come, or it's going to come so late that you have a stroke and it's permanent, or you have a heart attack and you don't survive. We need to talk about it. And, when you talk to officials, what you're going to hear is, and we think that we've turned the corner on this, but you may hear, well, wait a minute, these guys get all these insurance payments. They don't need more money. We don't need to pay them. They should just learn how to run better. And it's just not reality. And so we talk through this process, get more people to understand that it's an issue. And I think we're gonna be able to roll this forward and get it funded correctly and get it operating correctly.
Okay, well, thank you guys. I think it's really, really important. It's really great that you guys are shining a light on what I think has been a hidden challenge in this community, hidden challenge in the state, that could affect people's lives and ability to keep thriving and living. Thank you very much. We will be sending the video and the report out to people, and hopefully we can get people to engage and help support this.
Dave,
thank you everybody for joining us.
Dave, real quick, I'm sorry, I put my email in the chat. I see there are some questions that we didn't get to.
Right.
If folks have those questions and believe that I was the right person to answer them versus Chip or Paul, they can feel free to shoot me an email and I'll do what I can to get back.
I'm going to send you a whole bunch of questions that are sitting on my desk here too. So
great, thank you.
We will get them to you. Thank you everybody for joining us, and we'll see you again. We're doing another one of these in April on education and what's going to possibly happen in education in Berks County.
Dave, thanks for the opportunity to do it.
And everybody have a good day and enjoy this first day of spring.
Outstanding. Thank you.